In this lecture, I am going to focus on ECMO. See, ARDS is common in 10 to 20% of ICU patients. Among all ARDS patients, 10 to 20% develop severe refractory hypoxemia which fail to respond to conventional ventilator strategies, that is low volume ventilation strategies and prone positioning. Such patients may require ECMO. Nowadays, ECMO has become more reliable with improvement in equipment and increased experience, which is reflected in improving outcomes in recent studies. ECMO involves draining blood from venous circulation, pumping it through an artificial lung where oxygen is added and carbon dioxide is removed, and then returning the warmed and purified and oxygenated blood back to either the venous or arterial circulation. ECMO membranes may be of two types: silicone membrane oxygenator and hollow fiber oxygenator. The oxygenator consists of a thin silicone sheath in the silicone type separated by a plastic screen spacer. The silicone sheet is wrapped around a polycarbonate core and housed in a silicone sleeve. The blood passes on one side of the membrane, whereas the sweep gas flows in the opposite direction on the other side of membrane. And this gas exchange device is very efficient and may require the reintroduction of carbon dioxide through the sweep gas to raise the circuit carbon dioxide to physiological levels. Hollow fiber type consists of capillary tubes that allows the gas exchange via a counter current mechanism similar to that found in the silicone membrane oxygenator. The advantages to HFO include the ease and speed of circuit priming, a coating that reduces the risk of clot formation, a lesser surface area that reduces the platelet activation and inflammation, and a lower pressure gradient across the membrane which decreases the shear stresses on the red blood cells and the chances of hemolysis. If you want to increase the oxygenation, the blood flow rate, that is the pump speed of the oxygenator, has to be increased. The typical ECMO flow rates for an adult are between 60 to 80 ml per kg per minute. If you want to remove the carbon dioxide, the counter current flow of fresh gas has to be increased. The fresh gas flow is also known as the sweep gas flow, is maintained at 1 to 2 liter per minute. Now regarding the anticoagulation. The clots may form in ECMO circuit or be introduced into the patient's blood. This can lead to loss of circuit and lots of blood is wasted along with it. Even thromboembolic complications may also be seen if anticoagulation is excessive. Bleeding can occur, which is the most common complication of ECMO. To prevent this complication, the calculated and corrected level of anticoagulation is required, which is provided by unfractionated heparin infusions, which remains the predominant anticoagulation agent during ECMO. The infusion dose is titrated to activated clotting time of 180 to 210 seconds. The thromboelastography is a useful adjunctive device which can be used to titrate the anticoagulation, and also the platelets which are continuously consumed during ECMO require monitoring, and they should be kept at least more than 50,000 per microliter and hence require the platelet transfusion. The main indications of ECMO are the severe refractory ARDS, COPD exacerbations, and as a bridge to lung transplantation. VA ECMO is very useful in cases of cardiogenic shock, post-heart transplant as bridge to the transplantation, During veno-venous ECMO, the blood is extracted from vena cava or right atrium and returned to the right atrium. VV ECMO provides the respiratory support, but the patient is dependent upon his or her own dynamics or hemodynamics. During VA ECMO, blood is extracted from the right atrium and returned to the arterial system bypassing the heart and lungs. The VA ECMO provides both respiratory and hemodynamic support like a bypass. VA ECMO has the advantage of providing complete cardiorespiratory support and is therefore applicable in patients with very poor cardiac reserve. The left ventricular ejection fraction less than 25%. The only absolute contraindication to ECMO is a pre-existing condition that is incompatible with recovery. Severe neurological injury and stage malignancy are some examples which are absolute contraindications to ECMO. The relative contraindications can include uncontrollable bleeding and very poor prognosis from the primary condition. If you institute the ECMO in case of respiratory failure within 7 days of intubation, the chances are better. Now regarding the cannulations. Right or left common femoral vein is used for the insertion of drainage cannula and the right internal jugular vein is used for the insertion of infusion cannula. So there are two types of cannula. The 31 French being the largest and most appropriate cannula size for adult males. The tip of the femoral cannula should be placed near the junction of IVC and RA, and the tip of the IJV cannula should be placed between the junction of SVC and right atrium. Now let's talk about the complications of ECMO. So the most common complications of ECMO are bleeding and thromboembolism. The bleeding is most common complication which occurs in 30 to 50% of the patients on ECMO and can be life-threatening. The systemic thromboembolism due to thrombus formation within the extracorporeal circuit is a complication which can be devastating, with one report suggesting the rates of pulmonary embolism as high as 16%. So you have to be very careful. Now, what is the evidence to use ECMO? Does it change the survival? The conventional ventilatory support versus extracorporeal membrane oxygenation for severe acute respiratory failure, that is CSER trial, which was conducted in 2009, included 180 patients which were randomized to either be referred to a single ECMO center in the United Kingdom or undergo continued conventional ventilatory management. The group which was referred to the ECMO center has better survival without disability at 6 months compared to the conventional ventilatory management. Conclusion of CSER trial was that the adults with severe acute respiratory failure should be referred to ECMO center, specialized experience of ECMO. Another trial which was quite bigger than CSER was published after 9 years of CSER trial, called EOLIA trial. The ECMO to rescue lung injury in severe ARDS, EOLIA 2018 trial, which randomly assigned 249 patients with severe ARDS with PF ratio less than 50 for more than 3 hours, or PF ratio less than 80 for more than 6 hours. As soon as the entry criteria are met, VV ECMO or conventional low tidal volume, low pressure ventilation, which could include late ECMO as a rescue therapy. Okay, the ECMO resulted in improved oxygenation, more days free of renal failure, 46 versus 21%, and fewer patients with ischemic stroke, 0 versus 5%. Although the study was stopped early by the Data Safety Monitoring Board for interim results saying that the ECMO is better, this landmark study supports the conclusion that the patients with severe ARDS who fail to conventional optimal treatment should be managed with ECMO promptly rather than later as a rescue treatment. Now there is one meta-analysis of 2 randomized trial and 3 observational studies which reported The 60-day mortality rate was lower in patients receiving veno-venous ECMO. The mortality rate was 34% versus 47%. Now, main points you must remember about ECMO. Patients with severe ARDS who fail to respond to the optimal treatment should be managed with ECMO promptly rather than later as a rescue treatment. Due to its complexity, patients require ECMO. Due to its complexity, the patients requiring ECMO are best cared in the centers which use this technique regularly. So there should be ECMO centers which should be installed in each city, okay, and the patient should be referred to the dedicated ECMO center for its better efficacy. Now all intensivists must take proper training in running ECMO because this is the present and future of critical care practice. So with these points, I conclude my presentation. Thank you so much for your attention.